Welcome, everyone. My name is Sarah Webster, and I'm the Knowledge Broker with Niagara Connects. And if you're listening right now, I hope you're in the right spot. This is for the webinar entitled How Community Health Centers Are Changing the Health and Wellness Landscape in Niagara. We do have lots of people on the phone and on the line. If you're on the line and you're saying hello, we're not answering. It's because all of the participant lines are muted to help us cut down on background noise, fire alarms, dogs barking, and also allow those people that are joining in groups to be able to have sidebar conversations privately without us all hearing them. The presentation is being recorded. We record all of our webinars through the network, and we will post that recording online on YouTube within about a week, and we'll send an email out with the link to the recording as well as slides and other resources to everyone that's registered within that time frame. So certainly if you have a colleague who wasn't able to participate today, we encourage you to forward that information on to them as well. Other than that, we do, because the lines are muted, we'll hear our presenters speak for about 40 minutes. But during that time, if you have any questions, feel free to use the chat pod down the left-hand side of your screen. Just type any questions or comments in the box at the bottom there, and we'll keep an eye on that. And if it's a tech question, we'll answer it in the moment in the chat pod, and any other questions we'll flag for discussion at the end. And we will save some time at the end of the presentation for that discussion. So as you can see on your screen, we do have presenters here taking the time in their afternoon, which is wonderful to join us, from all 4 CHCs in Niagara. And the presenters today will speak to the community health center model and provide evidence of the impact of that model and some of the programs that are happening. So without going on too much further then, I'd like to first pull up some polls on the screen to help us get a sense for the first one for what sector you work in. So if you can take a moment and select all sectors that apply to your work, and we'll just have a look at who we have on the phone today. So as the numbers are coming in, I can see here that we have a heavy health representation, but also representation from public health, community services, housing support, mental health and addictions, and some others. There's always some in the other categories. I myself am a job that usually falls in the other category. So thank you, everybody, for joining us, and some government as well. Perfect. Put up one more poll here. To kind of get a sense, just in terms of experience, what type of professional contact you individually or within your organization have had with community health centers in the past year. And here we're seeing lots of other, but really there's quite a split across those of you that have client referrals, shared clients, sit around common planning tables or networks and or partnerships. So we'll hear from the presenters today about some of their client level programs that they offer, but also about some of those more broad cross-sector work that they're involved in too. So I'll turn it over now to Jenny, our first speaker, to take us away from here.
Hi, good afternoon. My name is Jenny Strangis, and I'm with Quest Community Health Center. I'm the program director. And so we're going to talk a little bit about CHCs in general. These are the CHCs that are on the line currently. We're going to talk about our sort of general approach, what we are, and we're also going to talk about some of our positive outcomes across the Niagara region, some of the particular program areas. And then we're going to end up talking about Community Health and Wellbeing Week, which is this week. Very timely. So I'm not sure where people are at with knowing about CHCs in general, so we're going to start from the bare bones basic. So community health centers, what we are is not-for-profit, community-governed organizations funded through our LIN, the Local Health Integration Networks. And what we do is provide comprehensive health services. Those are important pieces. The not-for-profit community-governed means that we're governed and we're shaped by our communities. But also the not-for-profit piece means that we're salaried across the board, from physicians to front desk to all our staff. This allows us to deliver services based on the client need rather than what's billable. So what you won't find in CHCs are charges for forms, charges for transferring files, charges for missed appointments, or those type of expenditures, or those one issue per visit. Those are all around billing, and so because we're non-billing and we're salaried, we can shape the appointment around the client's need. We also don't require health cards for that reason. We collect health card information. It's important for referrals and sending people forward, but we don't, it's not a barrier to accessing care. We see people without health cards and we help them get health cards. What we do is we focus on primary care, health promotion, illness prevention, community capacity building, and service integration. Each one of those are an important factor of what we do. It's not just about the health of the individual, it's about prevention and health promotion, but it's also about building healthy communities and linking the services we deliver with those around us. So we work very closely with all our community partners, many of which I see are listed online today, so you're probably aware of that. We work very closely with Child Protective Services, with social services, with mental health and addiction services, because it's about creating sort of service hubs and working across sectorial with individuals to ensure comprehensive care for our clients. So who we serve is individuals who face barriers in accessing health care. So we've been around in Ontario since the 1970s, and specifically looking at those populations who don't have ready access to health care. So they may have experience barriers because of their low income, because they're isolated seniors, part of the francophone population, part of the lesbian, gay, bisexual, transgender population, individuals struggling with mental health or addiction issues. Could be because of newcomers to Canada. Also can be geographic isolation because where they live there isn't health care readily available to them. So we are really, any of those populations, and each CHC has a certain defined priority population or priority populations that they serve, but usually they fall in the, basically always fall within those populations who experience barriers. And so our services and our programs in each of our CHCs are designed to meet the needs of not only our priority populations, but the communities in which we have our CHCs in. So we all look a little different. We all have a lot of the core features that are very similar, and we'll talk a little bit more about that, about the interdisciplinary team, about being community governed, but each one of us shapes our programs and services to meet the needs of both our priority populations and the communities in which we are located. And in Niagara, we're located throughout Niagara, in Welland, in Fort Erie, and Port Colborne, in Niagara Falls, and St. Catharines. Each one of them has a CHC. Port Colborne and Fort Erie being Bridges, who has two sites. Niagara Falls CHC, Niagara Falls, and of course Quest CHC, St. Catharines. So we focus on delivering primary health care services as well as a variety of health promotion and illness prevention programs. As well as community development programs. So we look at our services based on addressing the full gamut of the social determinants of health. We know that things that make up good health for individuals is more than just treating their disease process. It's also about ensuring food security, having safe, secure housing, having social networks. All those pieces go together to create the health of the individual and the health of the community. An example of that is when you look at, for example, diabetes management within a CHC. So yes, blood sugar levels and diabetes education are core and important, but included in that when you take the wider social determinants of health is ensuring that they have access to the medications they need and they have a way of getting them, ensuring that they have transportation to their appointments, ensuring that they have a safe place to live and store their medications. All those also greatly impact the health of the individual. In general, CHCs make up Tommy Douglas's second stage of Medicare. It's the second stage of Medicare brought to life. For those of you familiar with Tommy Douglas, he's really the father of our healthcare system in Canada, and he identified sort of the need for a single-payer healthcare system that was accessible to all, which we've realized in Canada. But the second stage, he said, was just as important as that first stage. We need to focus on health promotion, illness prevention, and building healthy communities, or he identified that the first stage would never be affordable. So if we only look at working downstream and doing sort of disease management after the fact, our system won't be balanced and we won't be able to sustain it. It has to have the second stage as well, which is a lot of what CHCs focus on in addition to the primary care, health promotion, illness prevention, community building. So when you look at our CHCs, we're made up of a variety of different healthcare professionals, from our client coordinators, front desk people, to our dental coordinators, our physicians, nurse practitioners, dietitians, health promoters, community health workers, social workers, registered nurses. All those interdisciplinary team members work together in a shared care model. So they share client bases. It's not about having a physician in your physician's office. It's about having a team of healthcare professionals that wrap services around you, trying to meet all your needs within that one hub. Again, working with our community partners as well when we don't have those services in-house. When you look at sort of our general approach, we adapt the approach of the model of health and well-being. And what that talks about, if you see the diagram up on your screen, talks about high-quality service that are people and community-centered, talks about focusing on health equity and social justice, all very important. We can't assume that everybody has equal access to health care, and we can't assume that social justice issues don't impede on people's general health and well-being. We also look at community vitality and belonging as being core to building healthy communities and ensuring the health of the individual. This actually, being Community Health and Wellbeing Week, our focus for this year is actually community vitality and belonging. So when you look at the model, we also talk about it being grounded in community development. CHCs have a long history of community development work. Again, building the health of the community helps with the health of the individual. It's core to ensuring that the people take ownership of their health and that they're able to sustain it over time. We all are based on the social determinants of health, so it's not about simply looking at the disease model, but looking at the larger picture. CHCs are all community governed, interdisciplinary, coordinated services. They're accountable and effective. We'll see that a little later when we talk about some of the research that's been done in CHCs, but we also are accountable to our local health integration networks that set our sort of budgets, but also set our expectations for care. And we look at population-based needs as well as the needs of the individual, and we're always looking at ways that we can increase our accessibility. So when you look at CHCs, for example, where they're located are typically in areas that are generally occupied by individuals who experience barriers to care. We also look at ensuring that we have points of service out in the community, that we have outreach work, that we do home visits. Each CHC is a little different, but the notion is, how can we ensure that we're as accessible as possible to care? And we also come from an anti-oppressive framework and ensuring that we're anti-oppressive as well as the culturally safe. So when you look at our approach in general, it really lends itself well to the triple aim approach, which you might recognize as being up on the screen right now. So it's about a healthcare system that keeps people healthy, gets them good care when they're sick, and will be around for their children and grandchildren. And that's the triple aim approach, looks at population health, experience of care, and per capita cost as being equally weighted. That you need to ensure that all those factors work together in order to create a high-performing healthcare system. And so when you look at the triple aim measure, we're going to highlight some of our programs that generically, from a triple aim approach, how they meet those objectives. I'm going to start out with talking a little bit about Quest, one of Quest's programs, and that's our Urgent Service Access Team. We also refer to it as our USAT team. So our USAT program is a partnership, again, integrated service, right? So it's a partnership with the NHS, Niagara Health System, CASN, and Canadian Mental Health Association, as well as Quest. And it's focusing on servicing individuals throughout the Niagara region, and specifically those individuals who frequent the ER for their care, so specifically with mental health and addiction issues. So those individuals who are reliant on the ER system for their primary care, basically, as well as those experiencing opioid dependency. The goal of the program, it's a mobile team that goes out to where clients are at, again, accessible, and it looks at wrapping an interdisciplinary care team around the client and connecting them to ongoing primary health care services. We know that their needs aren't being adequately met in the ER. It's not what the ER is about. It's not what they're supposed to do. But people are reliant on it because they don't feel they have other options. So how do we get them reintegrated or integrated into larger the larger healthcare system and really start to address some of the underlying factors in the social determinants of health to keep them healthy. The focus is on being flexible in our service delivery and ensuring that it's informed by our clients. We also look at eliminating wait times. We know with this population, there can't be a wait. It has to be ready-made, available service that responds rapidly to their needs so they don't fall through the cracks. And when we've surveyed and evaluated our program, we find that this style of service delivery is really working, as we have a 98% satisfaction rate amongst our clients. Over the last year, we've had 227 clients served through 2,960 encounters. That's times that we've had visits with them. And we've completed 400 referrals for that population to community agencies, again creating those secure linkages and those warm transfers to other services. USAC clients, the results that we're finding through our evaluation is that those clients who typically were the highest ER users in the system, we're finding that once connected to our services, 50% of them don't frequent the ER anymore. Their needs are met elsewhere, and the remaining, we see a 70% drop in ER use by this population. So again, having a client-centered, responsive team, being able to move clients along the continuum, get them firmly connected to the services they need, makes a big difference. And also, when you think about not only the population and the experience for the client, it also saves the system funds, right? Because every time a client attends the ER, it's quite an expensive service, and they're not getting the right service. We're paying top dollar, and we're not getting the right service for their need. So it also saves the system money and be able to allocate that money in ways that make sense for the system.
Okay, it's Lori Kleinsmith here from Bridges Community Health Center. And as Jenny mentioned, we have two locations, one in Fort Erie and one in Port Colborne. And I'm going to talk next about our physiotherapy services and our expansion into offering this into our communities. So a few years ago, Bridges was able to bring on physiotherapy services that were initially available only for our internal primary care clients. And this past spring, we received additional funding through our local health integration network, and now we have been able to expand our physiotherapy services to our residents in our catchment area, Fort Erie, Port Colborne, and Wainfleet, who do not have third-party health insurance. So by offering this, this is able to reduce some of those cost barriers that people may face in terms of needing to access physiotherapy services. So our services are delivered by a physiotherapist and two kinesiologists who work between our two locations and include one-on-one treatments as well as group exercise programs. These services are aimed at providing our clients with the knowledge and tools to incorporate physical exercise independently. And there is no physician referral necessary for physiotherapy services, so we're in the process of promoting this new service out into the community and letting people know that they can call in and self-refer if they feel they would benefit from physiotherapy services. Our target for 2015-16, as I said, we've just started offering the services more broadly for community members this past summer. So we're targeting to have 300 clients served between the individual services and 400 participating in our group exercise programs. And we know that by offering this service and reducing the cost barrier, that we will be reducing unnecessary diagnostic tests for various chronic pain needs that people may have. Hopefully as well we'll see a decrease in reliance on the need for prescription medications for pain management, decreasing visits to emergency departments, and eliminating or reducing waiting times for consultations. And many times these may be unnecessary consultations. So if we can enable people to be more empowered to take control over their chronic pain management through accessing physiotherapy services, we feel that this will be very beneficial to the health of our communities.
Great. Thank you, Lori.
Okay, so hello everyone. My name is Allison Baring and I'm the health promoter with the Niagara Falls Community Health Center. So we are located in downtown Niagara Falls on Queen Street. So I'm going to be talking a little bit about the Caring for My COPD program. So for those who may not know, COPD basically just stands for the chronic obstructive pulmonary disease. So the program is offered by both the Niagara Falls Community Health Center as well as Centre de Santé Communautaire, Hamilton and Niagara. So these are the only two sites in Niagara that are currently offering the program. However, it is offered at a total of 4 CHCs in the Hamilton, Niagara, Haldeman, Brant Local Health Integration Network, or LHIN. So the program is a free program, which is a 10-week program intended for those who have been diagnosed or recently hospitalized due to their COPD. So it's really intended to help those with COPD manage and then also to be able to gain better control of their disease, which in turn is basically going to be able to provide them with a better quality of life. So in order to join the program, clients are typically referred by a family physician, by a specialist, or through their hospital discharge. And then within the program, it really offers a lot, so both individual and group educational counseling and peer support services. So for both the clients as well as their family and caregivers, so not just for the person who has COPD, but also for those who may be caring or supporting them within their disease as well. So in addition to the education and the counseling, clients also have access to exercise programs. So for the Niagara Falls program, for example, we are located at the McBain Community Center, so clients have access to all of the equipment there. And then they also have access to other services, including smoking cessation support, and they can also be able to see any kind of other healthcare professionals, including a kinesiologist, a physiotherapist, occupational therapist, and also a dietitian. So all of those staff members do attend that location and are able to provide the support and education and counseling on hand. So by offering these programs, CHCs are able to offer quite a few benefits to the healthcare system. So this is going to be in terms of reduced costs related to the number of COPD-related ER visits and also other hospitalizations. So because this chronic condition can be managed within a community setting rather than within a primary care setting in the hospital, the cost is obviously going to be much more affordable in regards to having this in a community rather than dealing with it with a physician in a hospital setting. So it is a fairly new program. Between March and August of this year, the 4 CHCs total, so all 4 of those within the LHIN, have seen a total of 204 COPD clients, and with it being so new, we're hoping to really just focus on gradually increasing that capacity and be able to see and service more clients with COPD.
Thanks, Allison.
Hi, it's Jean from the Centre de Santé Communautaire. Sorry about my voice, but it's just that time of year. So Niagara Southwest Health Link is run out of Centre de Santé. Originally, it's my understanding that a variety of different organizations throughout Niagara had the capacity to house Health Link, and our peers were asked to choose, based on different Health Links, who they felt would best represent their clients and so on. And so we were actually chosen by our peers, so by other community organizations and by primary care providers in the region. So it is based at Centre de Santé, not in our main site in Welland on Main Street, but at our former site at 1 Banyan Drive in Welland. The team comprises of myself as the lead. We have 1 case manager, and we also have a community paramedic. The goal of the Health Link is really to better address the needs of the most complex and most vulnerable individuals in our area. So for Niagara Southwest, we cover Welland, Port Colborne, Pelham, and Wainfleet. Furthermore, we also make recommendations to the LHIN, and in turn, the LHIN makes those recommendations to the Ministry of Health and Long-Term Care on any of the system gaps and care pathways that we identify along the way. The major goals really are to target the 5% higher users in our population. We have a number of different ways in which we're able to identify who those patients are. We use the IDS, which is a system out of the LHIN and Mass University that's able to look at all of the clients' emerge and hospitalization use throughout the entire LHIN. So that's one way. The other way is, of course, through emergency departments. They can identify clients that attend frequently. We can also use Clinical Connect to identify those clients, and we receive referrals not only from the emerge department but from discharge planners as well as primary care providers in our area. So we're in collaboration with all of the primary care providers in our area, Niagara EMS, of course, and we do have that full-time community paramedic, the Niagara Health System, mental health and addictions agencies, and all kinds of other agencies throughout the Niagara region are helping us bridge the gaps in services for this complex population of 5% high users. We started seeing clients around the third week of January 2015. Our particular Health Link has provided services and taken on about 55 clients thus far, which is pretty good because we were our target was to target at least 50 people per year, so we certainly have that goal. The early results, and these results are LHIN-wide, are indicating a reduction in ER visits and admissions, as well as 30-day readmissions, anywhere from 30% to 40% for all of the 11 health links in the Haldimand-Brant Niagara LHIN. Our health link, however, would be on the higher end of that. We're seeing at least a 45% and possibly higher because this data is a bit dated now. There is a full cost analysis underway, not only at the LHIN level, but Niagara Emergency Medical Services is also preparing cost analysis. And probably the next bullet should have gone under patient experience, but we have partnered up with the Brock University iEquip team, and so we are working currently with 2 second-year medical students and 2 health sciences students in developing a way of measuring satisfaction, so a satisfaction survey of sorts. And the Brock iEquip team is also looking at the gaps that we've shared with them and are also looking at coming up with possibly some care paths or additional solutions on how to best meet those gaps in services. Thank you.
Those are some great examples from the different CHCs, each highlighting a different area that they specifically really highlight the work, AAA work done within CHCs. I'm going to talk a little bit now about some of the studies that have gone into evaluating, or additional studies that have gone into evaluating CHCs. Specifically, I'm going to start out with one called Value for Investment Study. And this was done across our LHIN. And what it looked at was, when you look at CHCs and the investment in CHCs, how we compare it to other models as far as the value we bring to the healthcare system. And so we looked at the use of ED, emergency department users, high users across the LHIN in 2012 and 2013, and identified that proportion of ED visits that are classified as best managed elsewhere. Typically what that means is they presented at ER, it could have been supported or managed in the community, but they chose to go to ER to have their issue addressed. And so it looked at comparing CHC clients with general LHIN clients from other healthcare models. And it identified 926 clients from CHCs that were examined in the study, all that were within that top 5% of healthcare users in each CHC. So they frequented the CHC frequently for healthcare. They came for a lot of appointments. And generally what the study found was, when you look at CHC primary care frequent users and their emergency room department usage, that they found that the care through the interdisciplinary wraparound services in the primary health care services actually reduced the amount of ED visits. So these were clients who were very complex, very ill, had a lot of complications to their health care. But what we found was 2.4% of ED visits were made by this client for conditions best made elsewhere, compared to 6.3 for frequent users of other models throughout the LIN. So the clients that attended CHC basically visited the ED 3.9% less than overall system when you compare for similar populations. The study highlighted CHC's success in providing that comprehensive wraparound client-centered approach that focused on prevention as well and results in sort of a value for investment for the most appropriate use of those expensive healthcare resources. You find the references also online at the AOHC website. There's another study that we looked at in 2009 that, again, focused on the evidence of CHC's success in Ontario. And it did a cross-sectional survey that looked at 137 randomly selected primary care practices in Ontario from 4 different delivery models. And in that 137 were included 35 CHCs. And so it just did some general findings around the clients attending those models. And what they saw was CHCs demonstrated a 10 to 15% higher performance in chronic disease management and significantly higher rates in health promotion. So that focus on, again, keeping people healthy, doing some prevention work, but also keeping them out of the ER. They also found that the presence of nurse practitioners within CHCs, within the CHC model, there's a big focus on nurse practitioners working to full scope of practice, that the presence of nurse practitioners were associated with 10% increase in disease management scores. And also that the likelihood of health promotion subjects being discussed and charted, they do that by looking at what was charted in the client's file, was significantly higher in CHCs. And within that interdisciplinary team model, family physicians working at CHCs were much more likely to view health promotion as an integral part of primary health care. So individuals who work in the model really buy into the fact that health promotion and prevention are core to effective health care delivery. In 2012, there was another study done looking at over 11 million clients from 6 different primary care models in Ontario. And this was done by ISIS. And what they did was they compared complexity of care within the Ontario models, and they looked at CHCs serving populations that were from lower income, higher proportion, newcomers. So when they looked at sort of who's accessing care within Ontario, when you look at who's accessing care in CHCs, they found them to be from lower income quadrants. They found them to be having more of the social determinants of health complexities, as well as more of disease burden, more morbidity and comorbidities, in general chronic health conditions. Given that, one would expect to see that they use ER more, but what they found was actually the reverse. CHC clients, even though they were more complex, use ER much less than on other models that were serving healthier populations. ISIS looked at this through something that they defined as a SAMI score, which is the Standard Adjustment for Clinical Group Mobility Index. And what they did was they based it on SAMI scores for different models, different practices, based on their complexity of care, and then measured against ER usage. So when you look at generally community health centers, you look at them serving individuals who are poor resourced, have greater barriers to accessing care, but they're managing them at a much higher rate and more comprehensive than what they found. And that's evidenced by their care being managed within the primary care model and not attending to ER as frequently.
And Jenny, just to pause there, there was a question. Can you just give us what the acronym for ISIS is? Do you know it?
For ISIS?
Clinical evaluated studies, possibly?
Yes, I think so.
Sorry, I missed that. Can you say that a bit louder?
I think it's about Institute for Clinical Evaluated Studies or something along those lines.
Perfect. Okay, thank you. And we'll find it and put it in the chat room by just, there we go. Rob, thank you very much. Institute for Clinical Evaluative Sciences. Thank you very much. Sorry, Jenny, I just wanted to catch that before you moved on.
No problem. So that's sort of talking about our sort of clinical work. I think Lori's going to talk a little bit about our community engagement and advocacy work.
Okay, thanks, Jenny. Yes, as many of you on the line are aware, I recognize some of the names of participants in the participating today. Community health centers are very involved in community engagement and advocacy work throughout Niagara and even provincially and nationally. In Niagara's CHCs, we provide leadership for hundreds of different programs and initiatives. And I'm going to touch on the first three, and then Jean will step in and share some information on the C'est Mon Choix programs. So first of all, the Niagara Poverty Reduction Network, all 4 Niagara CHCs are involved in the network and are amongst 30 plus members, agencies from different sectors in Niagara, from healthcare and social service sectors, education, business, community, and so on, as well as many individuals and citizens from the community as well. The network itself is focused on addressing the root causes of poverty, and we have 3 main avenues for achieving that: by dispelling myths about living in poverty, improving collaboration and actions in poverty reduction efforts by all stakeholders, and engaging and including the community in our efforts. So just a few examples of some of the work that the Niagara Poverty Reduction Network, with contributions from the community health centers, have been working on. First of all, there are several public policy working tables in the network under the umbrella of the network, including basic income guarantee, living wage, housing, and transportation. And the community health centers are helping to support the work of these working tables in terms of raising awareness and understanding and engagement with our political leaders and community leaders on the need for public policy changes in many of these areas. As we know, again, these are connected directly in with the social determinants of health and ultimately the health of our clients and our communities. We've also, through the Niagara Poverty Reduction Network, helped to develop documents that were used most recently in the federal election, and last year around this time with the municipal elections, that used evidence and understanding of different roles that local and federal governments can play in terms of addressing or reducing poverty. And so we were able to share these with local leaders and to meet with many of them in the lead up to the elections to discuss and begin that relationship building and advocacy building. The network also does a number of different speaking engagements, and some of the community health centers are involved in their presentation panels to talk about what we know about poverty, and again to do the necessary and ongoing advocacy for change. And we're also very active on social media, so we encourage people to follow the work of the Poverty Reduction Network. Another example of engagement and advocacy that the CHCs have taken leadership on in the community is the recently formed Niagara Dental Health Coalition. This formed earlier this year and is working to advocate and build capacity for the expansion of accessible dental health services for adults and seniors who live on low incomes. As we know, dental health is very difficult and complex, and there are many of our clients and members of our communities who are unable to pay for or access necessary dental health care. So we are working to raise awareness of the issues and to do, again, capacity building and advocacy building to overcome some of these barriers, as well as to engage and enhance collaboration between existing dental health services. A couple of examples of the work that's been ongoing is a dental health intervention tool, which will be it's included in the resource section of the webinar slide, so you can have a look at that dental health intervention tool, which contains a number of avenues that people can access to try and find some coverage for dental services if they don't have it, or to see what they may be eligible for. We've also been doing some awareness raising through local media and through some social media. And the last point that I'll talk about is our Road to Empowerment project, which involved Niagara Falls Community Health Center, Quest, and Bridges. It was started as a community development project through funding received through the Niagara Prosperity Initiative in 2012. This funding was helped us to develop and deliver workshops and initiatives focused on empowering people who have the lived experience of poverty through skill building to better self-advocate and to ultimately advocate for action and change on the structural causes of poverty. So throughout the first year of our funding, we offered a 6-week self-advocacy workshops at our community health centers, had a total of 83 people participate. And since then, we've gone on to form community advocacy groups in St. Catharines, Fort Erie, and Port Colborne. And even though our funding for the project has ended, we are continuing to meet and work on with a number of the past participants from the self-advocacy workshops who've maintained an interest in staying together and working on issues related to stigma, discrimination that they face as a person who lives in poverty. And several of our Road to Empowerment participants have actually gone on to become very powerful community advocates, and you may have seen some of them in the Faces of Poverty series that's been profiled in the St. Catharines Standard. Some of them have met with local politicians. They've joined the Niagara Poverty Reduction Network and have even been participating in provincial consultations on poverty reduction strategies and the changes to Employment Standards Act, to name a few. So it's just great work that community health centers are doing to try and be facilitators and agents of change and act as support and allies out in the community, not only with our community partner agencies, but also with the clients that we're working with directly. And I'll turn it over to Jean to talk about her program as well.
Okay, so the program is called C'est mon choix. Loosely translated in English, it means it's my choice. And it is an anti-drug program. It's a community-based drug prevention initiative that's targeting Francophone youth between the ages of 10 and 24 throughout Niagara, Hamilton, and Burlington. The project aims to reduce not only drug consumption, but all of the risky behaviors associated with the use of either illicit drugs or the abuse of prescription drugs, taking prescription drugs that are someone else's, those smarty parties that we've heard about where teenagers get together and they basically stolen different colored pills from their grandparents or their parents, and they throw them all in one big bowl and they mix them up like Smarties, and they dare each other to take handfuls. And it's also to foster a better understanding of the physical, the psychological, and the legal implications and consequences that young people would face with drug problems. We've also learned through this that many of the children will say that they use drugs to relieve stress. So stress is a big issue with our young population. So the project consists primarily of educational workshops in almost all of the French schools in Hamilton, Niagara, as well as, I don't know the current number, but it's well over 20 French immersion schools throughout Hamilton and Niagara, and those workshops are given from the grades of grade 5 all the way up to grade 12. So they are specifically targeting behaviors associated with those age groups, and each and every one of the workshops, of course, is specific to those grades. The workshops are really interactive. Students are encouraged to use those little handheld devices, sort of like Who Wants to Be a Millionaire, those little handheld devices, to weigh in on different subjects and to comment. So it's really quite getting a really good response from all of the kids. It was funded by Health Canada about 3 years ago, in 2014, and we still have the funding until 2017. At that time, you probably remember seeing a lot of commercials about Health Canada and using prescription drugs and so on, and that's also part of that very same initiative. It's my understanding that they funded approximately 10 projects Canada-wide, so we were quite fortunate that we got one here in Niagara. Since we started, we've reached out to over 3,400 people not only throughout the school, but once a year in each of those regions, we put on sort of a bigger event. For example, last year we held a large youth roundtable in Niagara, and it was well attended by all of the high schools as well as most of the primary schools. And the reach there was from grade 7 to grade 12. What we did is we had an organization come in and train the grade 12 students to be leaders at their tables, and the roundtable was held by the youth for the youth. So it was very interesting, and we do have a full report on that if anyone is ever interested. We are currently preparing to host the same event in November for the Hamilton region. So the success of this initiative in meeting its intended goal is evaluated through a number of different ways. We've been using pre- and post surveys, and Health Canada has also developed individual surveys for this initiative. In order to be sure that we were targeting the right group in the right way, we put together advisory committees. So we do have an advisory committee of young adults up to the age of 24, and it also includes some parents of younger children. And we also have an advisory committee that's composed of students. And they've been really key to this because they can tell us whether or not what we plan to present will be well received in different age groups. They review all of our promotional materials, our workshops, and they provide us with a lot of feedback, and they also suggest different approaches and so on. So the program is slated to end in 2017. At that time, we will obviously have a full report on the data. So what we initially did is we did pull a lot of data showing drug use in Niagara and in the Niagara region, and we're certainly hoping that at the end of our 3-year period that we'll see some significant drops in both the drug use and the risky behaviors associated with that in the youth, francophone youth in Niagara and Hamilton. Thanks.
Okay. Oh, just waiting to switch to the next slide. Okay, so Community Health and Wellbeing Week, as it's Lori Kleinsmith on the line again. Just as Jenny had mentioned at the beginning of the webinar, that October 19th to 25th, 2015 is our marking Community Health and Wellbeing Week across Ontario, and every one of Ontario's community health centres celebrates it in their own unique way. And of course, one way that we're doing that here in Niagara is through our webinar, and we're very pleased to be able to do this. It's been a really interesting and exciting way to work together. But Community Health Week is really an opportunity to spotlight shifting the conversation about health and healthcare, not just focusing simply on hospitals and the care, but to the need for investments in upfront prevention. Instead of paying for the downstream consequences, and Jenny described that well at the beginning through the social determinants of health. So we're offering a variety of health and wellness programs at our different centers, and really there's probably too much to list all on here, but a few examples are different group exercise programs, some healthy eating workshops, resiliency skill building, managing diabetes, smoking awareness, community art projects, and celebratory meals with local politicians. So I would suggest on the next slide that you can visit the websites for the different CHCs in Niagara to get full details on the different community health and wellbeing examples listed, as well as just our ongoing programs. We offer programs year-round, so there's much more that's being offered that's not just during Community Health Week. And we're very pleased to have community partners help with referrals into those programs and just to help us spread the word on the programs, because for the most part they are available to the broader community, not just to people who are accessing our primary care services.
Wonderful. Thank you to Jenny, Lori, Allison, and Jean for the presentation today. I'm going to pause. I see that we do still have some time here for questions. So if anyone on the phone or in the room would like to ask our presenters any questions about what you've heard today, you can either type questions in the chat pod on the left-hand side of your screen, or you can verbally ask questions by unmuting your phone line by pressing *7. I do see that Liz had asked a question, and I believe, Jenny, this was during, I'm just going to actually flip back. I think it was during the ISIS, during your slide here. And Liz had said, given the restrictions on who can access CHCs, isn't the first finding then obvious? Maybe I can ask you to just respond to that.
The first finding being that they tend to be more complex and have score lower on social determinants of health. Yes, generally that's who CHCs are geared to serve. Although there is the difference between urban and rural CHCs, and rural CHCs are geographically isolated as well. They're not. It's not necessarily individuals solely who struggle with income or mental health and addiction. So it's a bit of a mix between the urban and the rural. But yeah, generally CHCs do serve more complex clients.
Perfect. Thank you. And while we wait for if anyone else is typing questions in, I'm going to flip forward here and just leave this up for a minute. Some of the resources that were talked about today, I know Sarah has put some links directly in the chat pod, but there's some as well on the screen for you. We also have a question. Are our CHCs in Niagara looking for additional opportunities to connect with community partners?
I can give our answer here from Quest, and I think I speak broadly for CHCs. CHC's integration within other community partnerships is part of our mainstream work. So always we're looking to expand our partnerships and look for unique and creative ways to link with our partners to ensure that there's less gaps between services for clients and things become more convenient for our clients.
Thank you. Natalie asks, for the Bridges CSC, are the CHC, I think, are the physiotherapy services different than those funded in OHIP clinics?
Oh, okay. So it's Lori here. I'm not familiar on what is funded in the OHIP clinic, so I can't speak to that directly. Community health centers are actually not. We don't bill OHIP directly, so all of our services are offered. All of our staff are paid through salary, so we're not doing direct billing through OHIP. We typically will provide the necessary one-on-one services and then refer people as appropriate into group programs or with take-home therapy and exercises that they can do on their own. So it's not necessarily meant to be intensive physiotherapy, say for WSIB claims and so on, but we do have a full-time physiotherapist on staff as well as 2 kinesiology staff.
Great. And kind of as a follow-up to that, Blair has asked, what barriers and successes are you seeing in providing services such as physiotherapy and the dental to those not insured?
Well, in terms of physiotherapy, as I said, it's been successful internally before we began offering the programs and services to the broader community. We've had a number of our internal clients who otherwise would not have been able to afford physiotherapy services are now getting the necessary services that they need on site. So absolutely, there are many ongoing successes with that, and I think we'll continue to see the same as we have more and more residents from our communities who do not have the third-party health insurance coming. Barriers, I think, would simply be, at some point where we just may start to have wait lists. I can certainly see that happening. We're not at that point now, but at some point that certainly could become a barrier. But we'll just continue to work with our staffing and scheduling to best accommodate that. In terms of dental, well, we're not offering dental services. You may want to speak to the Quest and Centre de Santé dental services, Jean or Jenny, in terms of what you've seen so far in terms of your on-site programs for dental.
So although we haven't been able to sustain funding for dental services for those individuals who are uninsured, here at Quest we have been able to establish a volunteer dental program for our Quest clients, registered Quest clients. So we, through the generous contributions of local dentists, hygienists, and assistants, we run 3 days a week a full restorative dental clinic for the clients of Quest. And some of the benefits of that have been individuals. I mean, when you think about dental services and the need, right? Individuals suffering from chronic pain, chronic infection because of dental issues, inability to chew and digest their food properly, and even a barrier around employment and socializing, as their teeth often get in the way of their ability to socialize effectively and secure employment. So being able to get their dental needs met here on site, although limited resources, has been extraordinarily effective, and also has reduced costs to the overall healthcare system, because often, given that they had no other avenues for dental services, they would show up at ER because of their intensive infections and issues with their dental care. So I think the barrier is that it's a volunteer-run program, it's a limited resource, and certainly would like to expand it and open it up, but currently it's only for Quest clients because of the lack of funding to do so. It's been a huge success with the population for sure.
Thank you.
This is Jean. So for Santé Santé, our services are limited to a dental hygienist, so it's more preventative care. She does have extensive training in any other sort of oral anomalies. So she is trained in identifying, for example, tumors on the tongue or in the mouth and those types of things. So she is definitely able to refer clients on if they need to be seen by another specialist or by a dentist. We do accept clients that are not clients of our primary care team. Of course, being the French Community Health Center, however, those clients must be able to communicate in French.
I would also just highlight that with that, the access to physio and access to chiropractic services, we've been able also at Quest to establish a volunteer chiropractic service. Those kind of auxiliary services, physio, chiropractic, really are critical for a lot of the individuals we support who, I know here at Quest, I can speak on our behalf, we have a lot of clients who really struggle with chronic pain and active addiction. And given their limited resources, they often don't have access to those services through insurance that others may have through employment insurance, benefits through employment. So being able to access the physio through Bridges and the volunteer chiropractic program through Quest really has helped them manage their pain in non-narcotic ways, which has been critical to both keep them out of emerge, keep them healthy, and provide those alternatives that don't spiral into increasing addiction.
Thank you. We have some more questions, and I'll put them to you in just a second. But please, as we start to do that, Sarah Johnson's going to put some polls up on the screen. So for everyone that's in the online meeting room, as we kind of wrap up this discussion and address these last questions, please take the time to answer the polls as they come up. Rob has asked, how can we best communicate and thus increase awareness and support for the CHC model of care and philosophy of health and well-being? Specifically awareness and support within the broader public, but also among care providers and health system administrators.
I can kick it off if you'd like, and I don't know if anybody else has anything to add, but I think, when you think about the interdisciplinary model of care, focused on the second stage of healthcare, focused on interdisciplinary shared care model, these are concepts that have been in CHCs since 1930, when they first were established, in Ontario since 1970. And we're revisiting them in the healthcare system today, often as if they were new concepts where they've existed in CHC. So it's a very good question. I think through opportunities like this opportunity to do this webinar, so thank you very much to Niagara Connects for this wonderful opportunity, but I also think through evaluation and research around evidence of the model, because it exists within our practice, it's flourished within CHCs for many years, and we're always, there's always that phrase within CHCs where we talk about we're the best secret in healthcare. Best kept secret in healthcare, because we're the least aware, made aware of model, although we've been around for the longest time.
Thanks, Jane. Any other comments on that? This question kind of piggybacks on that, but Marty asked, to continue Tommy Douglas's vision, are there plans to expand the CHC model across Niagara and Ontario, more so than it is?
Our association, the Association of Community Health Centers, is always advocating for increased access to CHCs. There's so many different populations that would benefit from the care provided by community health centers. So expansion is always on the horizon. And in Niagara, We have a great investment now in CHCs, but it took a long time. Other communities have had CHCs for 30, 35 years, where Niagara is much younger in the CHC culture. So expansion and growth of the CHCs, I think, can be expected, and expansion of the areas that we serve as well. Because although we have the French community served in Welland and across Niagara, but we also have, but predominantly in Welland, and then Fort Erie, Port Colborne, Niagara Falls, and St. Catharines. There's lots of areas in Niagara that don't have ready access and don't have ready transportation. So expansion to those areas, I think, is definitely on our horizon.
And we'll wrap up here with one final question. You mentioned that the CHCs don't require health cards. Do you require proof of residency or status in Canada? Do you offer services to undocumented people in the community?
CHCs try to remove barriers as much as possible. So we support individuals any way we can. So we try to remove barriers is the best way to answer that. So we look at the client, look at what we can do, and try to not have any wrong doors for anybody.
Great. And it's Lori here. Just to add to that, Jenny, in our Fort Erie site for Bridges Community Health Center, we do see a number of newcomers and refugees who are coming across the border, and we do not require residency or status at that point. It's simply being in our country. If you are a refugee who is still applying, or if you're many of them are in a limbo state, they're not hearing results of their applications for some time, and particularly with changes to the federal government's refugee health care, cuts to that health care. Many refugees have been unable or have had challenges with finding access to health care, and community health centers across the province have been stepping up to make sure that we are there to provide the services and supports that we can.
Perfect. Thank you very much. I see that it is 2 o'clock here, so we'll let everyone go with their afternoon, but this has been a great presentation. And on behalf of Niagara Connects, I'd like to thank everybody on the phone, the participants, for joining us today, and also to our presenters for all your work going into pulling this together, and of course your presentation today. As I said before, the webinar is recorded, and we'll follow up with a link to the recording as well as the resources and references that were talked about today. We'll send that communication out within about a week. But I've also put the link there in the chat pod to the Niagara Connects website, and we'll also put up the link for the NKE, the Niagara Knowledge Exchange. Connect with us, please. Join our distribution list. Through that, we send out the invitations for you to register for any future webinars. And we do have a webinar coming up in November on crisis service mapping in Niagara. So I encourage you, please do connect with us, and we look forward to talking to you all in the future. Take care, everyone. Have a great day.